Thank you for joining us for the IARS webinar today. My name is Richa Dhawan. I'm a cardiothoracic anesthesiologist at Northwestern Medicine. I'll be the moderator for this session. We have 3 fantastic speakers lined up today, and they're going to provide an update on donation after circulatory death heart transplant. Before we begin, there are a few housekeeping items. This webinar has received no commercial support. If you missed the 2025 annual meeting, there are on-demand recordings available. Registered attendees have complimentary access. For more information, you can visit this hyperlink. Please save the date for the 2026 annual meeting, which will be held May 1st to the 3rd in Montreal, Canada. As a reminder, abstract submissions will open later this month. You can visit meetings@iars.org for more information. After this webinar, you can join the speakers in the IARS member community to continue the conversation on today's topic. There are upcoming webinars, and you can visit iars.org to register for these. This is an interactive webinar, so we will open up questions at the end of the session. Please use the Q&A button on your Zoom taskbar to submit any questions that you have. So I'm going to go ahead and stop sharing. We're going to go ahead and get started. So please allow me to welcome our first speaker, Dr. Salerno. Dr. Salerno is the Chief of Cardiac Surgery, the Surgical Director of the Heart Transplant and MCS Program, and Co-Director of the Heart and Vascular Center at the University of Chicago. He's previously led transplant programs at St. Vincent Heart Center of Indiana and the University of Washington. He's an internationally recognized cardiac surgeon, author of hundreds of peer-reviewed publications, and a well-sought-after invited speaker. His clinical focus has been the surgical treatment of advanced heart failure. Welcome, Dr. Salerno.
Richa, thank you so much. And thank you everybody for attending. My job here is to really set the table and give some context of what we're talking about. These are my disclosures. I am a consultant for a few LVAD companies. You know, the background for all of this really is a ongoing need for more organs. We still have about 10% of all patients pass away on the wait list within a year. And that waiting times now are longer than ever, with almost 20% of the people waiting about 1 year. Traditionally, hearts were procured in a standard pathway where the donor was declared brain dead, and then a very controlled fashion, the organs were retrieved. There is a history using organs from circulatory death patients where the donor actually passes, the heart stops functioning, and then the organs are procured through one of 2 different methods. And this has grown in resurgence in the last few years. Let's just talk about the history of heart transplant, because this is important. The first transplant ever performed by Christian Bernard was actually a DCD heart transplant. And that never gained favor in the US. And when Dr. Shumway did the first transplant in the US, I was a brain death donor. But early on, there were no laws to govern this, and there was actually lawsuits surrounding this. Eventually, the term of brain death became something we recognized, which really was loss of brainstem reflexes and apnea in the donor. And this allows us to do a very controlled procurement where the donor with a beating heart is considered dead, the organs are fully assessed, and then they are visualized, preserved, and taken to the donor center. And what facilitated some of this was this idea of a dead donor rule. I think Kristin will talk more about this, but this is not a law. This is an ethical norm. And it basically suggests that whoever does the transplant should only take organs from patients who are passed and should not hurt the donor in the process of procuring organs. And therefore, when we talk about DCD, we have to worry, are we potentially hastening death? Now, DCD heart transplant we talked about was first done in 1967. And one I favor, but really for pediatric reasons, when donors were defined, it came back in the resurgence in the pizza space into the mid 2008. Eventually, programs in Australia and the UK brought this to vogue, and the outcomes were reasonable. And then there was renewed international interest. The biggest difference between this and what we do with brain death is this period of warm ischemia, where the donor has withdrawal of life support, and then they're allowed to pass. And most people wait 90 minutes to 2 hours for them to pass. Then there's a standoff period, which is based on the opioid. And then after all of that occurs, the organs are procured. This induces a period of warm ischemia, and an important term is functional warm ischemia, which is the time where the blood pressure is less than 50 and before the administration of a method of preservation. Now, this 5-minute standoff, which is normal, is in large part based upon this work from the New England Journal of Medicine that the people passed away. And really, after 4 minutes and 20 seconds of no significant heart beat, it's very, very uncommon for people to have a meaningful recovery. The donors we use are what we call matrix category 3, which are donors in a controlled fashion, not people who are dying outside the hospital or dying because of unsuccessful resuscitation. Most of the donors are 35 to 50, and they often are in situations that favors early procurement, such as no cardiac surgery previously. We have some information preoperatively, echoes, and now more and more CT scans to assess coronary anatomy. This data's a bit old, but when this started coming back on in 2019, there was already a visible impact of DCD heart transplantation. And this year, it may be up to 20 to 30% of all transplants in the US will be DCD. The initial data at a pathway is favorable, and that's why other centers developed interest. This is an important graph. And what it shows is after there's withdrawal support, the donor is allowed to pass. Ultimately, the blood pressure falls. And successful procurement really only happens if the organs are procured within 30 minutes of hypotension. There's two dominant ways to get these organs: NRP and direct procurement. NRP means, and this is the more controversial one, the donor dies, the standoff of the 5 minutes is done, and the team rushes in, opens the chest, and immediately excludes the cerebral circulation. ECMO, or equivalent, is performed with central cannulation. The organs are perfused, resuscitated, and then weaned from ECMO. If function looks good, procurement is then completed, similar to a brain dead donor. The teams will travel with a system like this, which is a portable ECMO circuit. This has several direct advantages. It's more controlled, less expensive, allows better assessment of organs, and there's some data that more organs will be procured. The initial reports from Vanderbilt is very encouraging. Their first 15 patients were alive and did well at 30 days. The alternate system is this transmesh-based direct procurement and perfusion. In this situation, after the donor passes, immediately the chest is opened, blood is collected to put in the circuit, the aorta is cross-cracked, and cardioplegia is delivered. The organ is then put on the system and transported while being back to the donor site, and it's being assessed the entire time. This data has now been published in the New England Journal of Medicine, and the bottom line is these organs function as well or better than equivalent brain death, I apologize, donors. Some organs are turned down, and they're turned down based upon metabolic activity. Once they're on the system, the lactate should trend down, and if it doesn't, the organs are excluded. The summary slide shows that the OCS organs up to 12 months have the same or better survival to brain dead organs. Likewise, heart-related adverse events were similar. So just to wrap up, in the US, this may mean 500 to 600 more hearts per year. The numbers are growing, and this year, my guess is to be over 400 to 600 in the US. There's been thousands done across the world, and in the UK and Australia, without this, there's not much transplantation. When you compare the two methods, there's a suggestion that NRP is less expensive, maybe associated with and better short-term outcomes. But there are ethical issues which Kristin will talk about. So just to wrap up, DCD heart transplantation has occurred since the first transplant. It appears to be safe and effective with equivalent outcomes. We expect to increase the donor pool 20 to 30%. However, lots more has to be done to figure out the best way to do this. Thank you so much for your attention.
Thanks so much, Chris, for that overview of NRP and OCS and DCD. So our next speaker is Dr. Ngai. Dr. Ngai is an associate professor at New York University Langone Health and specializes in adult and pediatric cardiac anesthesia. She obtained her medical degree from the State University of New York, Upstate Medical University, then completed her anesthesia residency and cardiothoracic fellowship at NYU. Since joining the faculty, she's developed a respected career with a record of achievements in building and leading prominent clinical education programs. She is the director of the Cardiothoracic Anesthesia Fellowship, the Cardiothoracic Anesthesia Division, as well as cardiac and lung transplant anesthesia at NYU Langone Health. Her areas of research interest include diversity in cardiothoracic anesthesia and cardiac transplant. So welcome, Dr. Ngai.
Dr. Dhawan, thank you very much. Just give me 1 second. Okay, great. I hope everyone can see the screen. Thank you for the invitation to speak with you today. I will be discussing the outcomes in donation after circulatory death compared to donation after brain death and heart transplant. So again, my name is Jennie Ngai. I'm from NYU Langone Health in New York, and I have no financial relationships to disclose. So it was about 60 years ago the first heart transplant was performed. As Dr. Salerno mentioned, advances in research and medications, preservation techniques, and surgical techniques have come a long way and allowed us to help many patients in need of heart transplants. In a bit, we'll go over some of the outcomes for donation after brain death and donation after circulatory death. The first heart transplant was actually DCD, as he mentioned, but subsequent heart transplants were DVD. The reasons for this will be discussed in the next presentation. You may notice QR codes in the corners of many of the slides, so please use them if you wish to scan for references. So as we've heard in the previous talk, DCD organs are being used more for heart transplants. Over the next few slides, we'll go over how many DCDs are being performed and geographic location of these transplants. The United Network for Organ Sharing, or UNOS, is an organization that tracks information about donors and recipients in the United States. This table is from the UNOS website from a few days ago. What is shown here are the numbers of brain death donors and circulatory death donors for heart transplants over the years. The top row are heart transplants from both DBD and DCD donors, the totals. The middle row is the number of DBD heart transplants, and the bottom row are the DCD heart transplants. As you can see, the number of DCD has increased each year. There were no heart transplants utilizing DCD hearts in 2018. And 6 years later, in 2024, there were almost 800 DCD heart transplants performed in the United States. So internationally, the number of DCD heart transplants has increased as well, and I'll show you that in a few minutes. But first, let's take a look in general at heart transplants around the world over several time periods. This is data from the International Society for Heart and Lung Transplantation, the 2025 report, showing transplants between 1992 and 2024. As you can see, the majority of transplants are performed in the United States, with almost 80% of all heart transplants, followed by almost 20% performed in Europe and the rest performed in other countries of the world. It also looks like there have been an increase in number of transplants performed in the most recent period, with 30% of total transplants performed between 2018 and 2024. DCD transplants comprise 2.4 transplants done between 1992 and 2024. This is the annual number of adult DCD and DBD heart transplants performed between 2015 and 2023. They're stratified by the donor type and performed globally. You may notice that there's a large increase from 2018 to 2019. The biggest and most plausible reason as to account for this might be from improved collaboration, data sharing among international transplant centers. Other reasons may include optimizing transplant processes, organ donation programs, the growing acceptance of heart transplants as a viable treatment option for end-stage heart disease, enhanced preservation methods for donor organs, allowing for longer transportation times and broader geographic distribution. The green bars near the bottom indicate DCD heart transplants performed are gradually increasing around the world. This is the number of adult DCD heart transplants between 2015 and 2023 by region. In recent years, most DCD heart transplants are being performed in North America. Overall, DCD heart transplantation has increased over time. It was just 3.6% of all heart transplants in 2015, and DCD heart transplants made up almost 15% of heart transplants last year. So a closer look at the data from ISHLT showed that between 2015 and 2024, DCD heart transplants were almost 10% of heart transplants, and DBD made up the other 90%. North America had the most heart transplants in general, with 80% DCD and 91% DBD. DCD heart transplants seem to make up more of the total heart transplants in both Europe and the rest of the world. In Europe, they did about 1,500 heart transplants, 1,200 of which were DBD, and the remaining 300 were DCD. And so almost 20% of heart transplants done in Europe come from DCD. Much of the early research was performed by groups in the UK, Belgium, and Australia. 24% of transplants in the world come from DCD donors, and in North America, just 9% of heart transplants are from DCD. A lot more of the research being done recently are from centers in the United States. There's been a big increase of DCD between 2015 and 2024, with the biggest increase in 2022 to 2024, with 75% of DCD being done in this most recent time period. Heart perfusion techniques, a relatively recent technology, is being used more in the DCD transplants, which may also explain the increase in the DCD numbers, since it enables evaluation of the viability of the donor organ. This demonstrates how much DCD is growing in the United States. The graph on the left shows a continual increase in DCD-capable centers over the past few years. And the map on the right shows a split between NRP and direct procurement, the percentage of DCD procurements using NRP or direct procurement. It's interesting to note the difference of the procurement techniques in the different regions. For example, regions 5, 8, 11, 2, and 9 employ NRP a fair amount, and regions 6, 10, and 1 do not use NRP at all. Because of the ability to evaluate and optimize hearts, the technology of using machine perfusion, or NRP, for DCD hearts may improve the utilization of organs. Currently, about 50% of potential donor hearts are discarded. Many people shied away from using DCD organs because of the uncertainty of organ viability after the period of warm ischemia. This data compares DBD and DCD heart transplants from the UNOS registry from 2019 to 2022. They looked at 13,000 brain death and 500 DCD cases. Transplanted DCD hearts are in the blue, hearts that were not recovered in green, and hearts that were recovered but not used for transplant are in red. They found that 10% of DCD hearts were not recovered after sternotomy, compared with 4% of DBD hearts. This meant that after procurement surgeons opened the chest, they decided not to take the organ based on visual appearance. In addition, 7% of DCD hearts were not utilized after recovery, compared to 1% of the DBD hearts. They did find that NRP hearts had a higher odds ratio of recovery and utilization compared to direct procurement hearts. Now let's take a look at how DCD heart transplant recipients do compared to DBD recipients. These are some of the studies that I took results from. I included a database and the study size. Many of the studies are fairly large and include both national and international data. We have studies from the ISHLT, the International Society of Heart and Lung Transplant, OPTN, the Organ Procurement Transplant Network, SRTR is a scientific registry of transplant recipients, UNOS is the United Network for Organ Sharing, and OCS is the Organ Care System Heart Perfusion Registry. The first thing we'll look at is 1-year survival. This is the single center data from 2020 to 2023, showing DBD and DCD 1-year survival, and they did not find any difference, with 92% 1-year survival for DBD and 94% 1-year survival for DCD. This survival data is from the OPTN, the Organ Procurement Transplant Network, 2019 to 2023, showing both 1-year and 3-year survival. 1-year survival for DBD was 93%, DCD direct procurement was 93%, and DCD NRP is 94%. 3-year survival is 84% for DBD, 83 and 87% for direct procurement and NRP. This is from the ISHLT registry, which includes countries from Europe, North America, and other centers around the world, showing survival within 365 days for adult DCD and DBD heart transplants between 2015 and 2023, stratified by the year and donor type. Both are above 90%. So the past few slides I've shown may appear redundant, but I wanted to show that multiple studies have shown that 1-year survival for DCD is very similar when compared to DBD. So this table is a compilation of the different studies and the 1-year survival for DBD and DCD heart transplants. Each of the studies show very similar, again, 1-year survival rates between DBD and DCD. Most survival rates are around 90 to 94%. Some of the studies also compared survival rates of the different DCD procurement techniques. Direct procurement had a lower 1-year survival compared to NRP, but it was not enough to be a significant difference in several of the studies. DCD NRP ranged between 91 and 95%, and direct procurement between 88 and 93% 1-year survival. Data from the OCS Heart Perfusion Registry, which collects data on U.S. heart transplants using the ex vivo machine, perfusion or OCS, cold storage or NRP, and then donor hearts from DBD or DCD donors. So they showed the survival of heart transplant recipients after DCD hearts were placed on OCS or machine perfusion after procurement was 93% at 6 months and 91% at 12 months after transplant. This compared favorably with survival of heart transplant recipients after DBD cold storage, which is 94% at 6 months, 92% at 12 months after transplant. So given the differences in baseline recipient characteristics between the two groups, they conducted a 1-to-1 propensity score matching on recipient diagnosis for congenital heart disease, multi-organ transplantation, durable ventricular assist device at transplantation, and medical urgency status at transplantation. Survival of the patients in the two propensity score matched groups was similar at 6 and 12 months with a p-value of 0.32. So this is also from the OCS registry, and they compared DBD using OCS and DBD using cold storage, and DCD using OCS and cold storage. There was not a significant difference between the groups when looking at rejection, kidney dysfunction, hospitalization, or CAB, which is cardiac allograft vasculopathy, during the first year after transplantation for either category. In multiple studies, PGD or primary graft dysfunction was not significantly different, p-value of 1. Neither was acute rejection or hospital readmission. CAB was also not very different when looking at DBD and DCD heart transplant. And from the UNOS data, secondary outcomes listed here, which are acute rejection, need for dialysis, need for pacemaker, post-op stroke. They were similar between DBD and DCD heart recipients. This chart also shows the analysis for all the patients and for the propensity score matched patients as well. Although it's not shown here, there were some differences in post-op use with VAD and balloon pumps. The overall use of MCS, mechanical circulatory support, was very similar, around 12% in both DBD and DCD, but balloon pump use was higher in DCD, and VAD and Impella use was higher in DBD recipients. ECMO use was similar in both DBD and DCD groups, but there was no explanation why the difference. It just may be institutions. Interesting also when comparing DCD direct procurement and NRP, there was no significant difference in these same secondary outcomes. We tend to think that the NRP is beneficial because of the ability to evaluate and optimize organ function prior to accepting the organ for transplant. The ability to use machine perfusion for the recovered organ has improved the outcomes of direct procurement organ transplants. Machine perfusion systems allow perfusion to the organ, allows blood gases to be done to check lab values to evaluate trends for organ function. Use of NRP and machine perfusion can both add to the cost of the transplant, as both require equipment and clinical expertise. The machine perfusion system may cost more than the use of NRP, but both are beneficial, and some programs have used NRP prior to procurement and then used machine perfusion as well during the transplant to the recipient institution. So this is another study showing the outcomes comparing direct procurement and NRP. Hospital stay was similar, as well as rejection and the need for dialysis. The final ejection fraction between the two groups is also very similar, which is great. And some worry that graft function would be affected by the different techniques. So in summary, DCD has increased over the past few years. Now approximately 15% of heart transplants in the world, 10% of DCD hearts are not utilized. Outcomes of DCD are very similar to outcomes of DBD recipients, as well as secondary outcomes. Long-term survival rates are not yet available for many institutions, but hopefully in the future we'll be able to see that DCD is a viable resource for organ donation, and perhaps with better technology to preserve and optimize donor hearts, we'll be able to increase the number of donor organs available. So thank you for taking the time to hear about the outcomes of DCD and DBD heart transplant.
Okay, thank you so much, Jennie, for that outcome data. We're going to move on to our next speaker, Dr. Trela. Dr. Trela is a cardiothoracic anesthesiologist and assistant professor at Northwestern Medicine. She specializes in heart and lung transplant, including DCD heart transplant, multi-organ transplant, robotic cardiac procedures, multivalvular operations, revascularization, and MCS. She has published on DCD heart transplant. Welcome, Dr. Trela.
Hi, thank you for having me. I'm going to share my screen. Okay, so it looks like we are good here. Okay. Okay, so excellent. So I'm going to be talking about the withdrawal of care and ethical considerations of donation after cardiovascular death. Okay, I'm Kristin Trela. I have no disclosures. I'm not going to be talking about any devices for today. So before I get into some of the ethical dilemmas surrounding DCD heart transplants, I think it's really important to review the withdrawal and donation process, so we have a shared understanding of what this looks like before we talk about the ethical considerations. So our story starts with a patient who suffers a very severe injury or illness that's usually neurologic, but doesn't have to be. Like often a anoxic brain injury is common, where recovery is deemed to be unlikely, or continuing care is not consistent with the patient's values, and the family has decided to withdraw life-sustaining therapies. And importantly, this patient does not meet criteria for brain death. And this is when the family is going to be approached by the Organ Procurement Organization, or the OPO, to obtain consent. If the family doesn't consent, then withdrawal of life-sustaining therapies occurs and end-of-life care is administered, as we are traditionally familiar with in ICUs, with emphasis on patient comfort. If the family does consent, then we go down this pathway to donation. Physiologic support is continued, in addition to testing is completed to evaluate which organs are viable for donation. Potential recipients are identified. When this is completed, the patient will be taken to a location that's most often an operating room, where withdrawal of life-sustaining therapies occurs at this time. If death occurs within a certain period of time, which is variable and determined by the OPO, then organs can be procured. So the family will be escorted out, and there's a mandated standoff period, again, most often 5 minutes based on the OPO, as it's thought that the heart will not restart on its own after this period of time. Then after the standoff period, the chest is entered and the organs are procured. And if death does not occur in the predetermined period of time, the patient will go back to the ICU and end-of-life care will be continued there. So for a little bit more granularity, because this is important later, the top graph represents what happens in donation after brain death transplants. So Dr. Salerno talked a little bit about this, but just wanted to show a graph of this. In this situation, the patient is brain dead, which is a legal definition of death, but they have an intact circulatory system. So when the organs are procured, there's no warm ischemic time. And this is in direct contrast to our DCD transplants, and both direct procurement and normothermic regional perfusion are illustrated here. Due to the fact that they all undergo circulatory arrest before procurement, there's always an obligate warm ischemic insult. This starts at the withdrawal of care at the point when the patient becomes either hypoxemic or hypotensive, through the period of circulatory death, through standoff, through the procurement, and then either for direct procurement where the cold preservation is given, or with NRP when the ECMO is started, right? All of that's a lot of time. So you can see how there's a really strong urge to try to recoup these organs and minimize the warm ischemic time. And before we move on to ethical considerations, I want to talk about the withdrawal process and how it's different for donors versus non-donors. And it's okay that that's true because it's ethically justified, because in theory, donation was within the donor's wishes for themselves. However, families do need to know what this looks like when they're consented, so they're crystal clear about what this will look like for them, okay? So donors will undergo premortem interventions that non-donors don't. They undergo continuation of care to help keep the organs healthy, like continuous monitoring, vasoactive medications, mechanical circulatory support, and they undergo a battery of testing. And some of that testing can be invasive, like left heart catheterizations, to determine which organs are appropriate for donation. And depending on the institution and country, they can undergo additional procedures like groin line placement to facilitate NRP, or have extra medications administered like heparin to facilitate the donation. And in addition, withdrawal of life-sustaining therapies looks really different for family members. Typically, if you're withdrawing care on a non-donor patient, you're in a dim ICU room, there's no monitors beeping in the background, where these patients are going to be in a bright operating room, right? Because the time to go from an ICU bed to the OR would make the organs unviable. So we're going to withdraw care typically in a PACU bay or in the operating room itself. It's going to be a bright operating room with a huge team of people waiting for your family member to die. In addition, patients and families will have an abrupt separation after death. In a non-donor death, families are able to spend whatever time with the decedent that they want, okay? And finally, families have to be prepared to return to the ICU if the warm ischemic time is too long and the organs aren't viable. So you have to prepare families for the fact that this transplant may not happen. A lot of people find a lot of solace in the fact that their personal tragedy contributed to some greater good. So they really do want this donation to happen. So if it can't, they can feel like a second grief. So you have to prepare them for this possibility. So no ethics talk would be complete without talking about the dead donor role. And so this is, like Dr. Salerno said, it's not like a law, but it's more of an ethical rule, I suppose. So patients must be declared dead before the removal of life-sustaining organs for transplantation, which seems fairly straightforward on the surface, right? We can't kill people for organs, okay? The Uniform Determination of Death Act defines death as either an irreversible cessation of circulatory and respiratory function or irreversible cessation of all brain function. And I bolded irreversible because it's really important in this context. So we're going to talk about irreversibility and permanence because these are actually different, even though they sound like synonyms. Irreversibility says function can't be restored no matter what you do. There's nothing you can do. Permanence says function won't recover in the absence of intervention, but this implies that you live in a window where you can do something to recover medical function, to cover function again, okay? So let's pretend that death can be on a graph. Let's pretend death's a graph, okay? So if y-axis is the potential of the recovery of function and the x-axis is time, okay, we can envision routes of death that are immediately irreversible with no possibility of recovery, like decapitation, for example, right? There's nothing you can do to fix that outcome. However, there is a pathway that's more typical of in-hospital arrest, where a patient enters a state of cardiac arrest, and let's assume it's immediately recognized. They're entering a state of permanence, or the function will not recover if you don't do anything, but there is a possibility to apply an intervention to reverse the outcome. So unfortunately, no matter what you do, patients do enter a state of irreversible death, which is probably one of our greatest sources of pain as physicians. But however, in a state of permanence, we can try to apply an intervention like CPR, mechanical ventilation, that can restore function. And this is more aligned with the pathway that DCD patients go through. After arrest and undergoing a 5-minute standoff period, either the patient or the organ is resuscitated, and the organs are restored such that they can be donated and live in somebody else's body and be functional. So it begs the question, are the donors dead? Do DCD transplants violate the dead donor rule? And there are two schools of thought. The first is that yes, they are dead. This is spearheaded by Dr. Bernat's work. He argues that DCD donors are dead once permanence is established. So after the 5-minute standoff period, the heart will not restart on its own without intervention. So we are in a state of permanence. And in other non-donation settings of withdrawal of care for other terminally ill patients, we establish this as the point of death. We don't further determine irreversibility because resuscitation is not planned to occur. So why would this be different for a non-DCD donor, or for a DCD donor, I should say? And he argues that DCD is compliant with the dead donor rule because it's accepted medical practice. We are declaring the patients dead, so thus they are dead. And the other school of thought is, no, they are not dead, right? Trog and Miller's work argues that permanence is not a proxy for irreversible death, that they are different. And a little bit of academic skewering, they actually took this quote out of context from Dr. Bernat's work to illustrate a point. Because no mortal can return from being dead, any resuscitation or recovery must have been from a state of dying and not from death. That if an organ can be removed, resuscitated, and live in another human for years to come, this isn't irreversible and violates the dead donor rule. However, they argue that even though this doesn't conform to the dead donor rule, it's acceptable because patients are allowed to decide how they die, and they are allowed to decide how their organs are donated, that they have autonomy. Then it begs the question, does NRP violate the dead donor rule more? Okay, so recall with NRP, organs undergo resuscitation in situ with intentional isolation of cerebral circulation. So theoretically, if other organs can be reanimated, would not the brain if not for clamping of the great vessels? And this leads to the question, is a surgeon artificially creating a state of irreversibility by creating a state of brain death in order to procure the organs? Is this euthanasia in order to obtain organs? Remember that the dead donor rule says that we can't kill people for organs. And there is additional concern that there can be blood flow to the brain despite exclusion of the great vessels via collaterals. There's a small non-randomized study from Spain that suggests that any collaterals are unlikely to provide adequate blood flow that would cause reanimation, but the concern remains regardless. And so NRP does remain controversial from an ethical standpoint. DCD has been described in these countries with any of the colors, either blue or red. And the blue ones have either paused or outlawed NRP. It is outright outlawed in Australia, where recirculation after declaration of death is not permissible with its current donation practices. And it's paused in the UK, where the technique was actually originally developed to evaluate the possibility of cerebral circulation in donors. My understanding is that abdominal NRP is still continuing because the cross clamp is much lower on the aorta, meaning that the possibility of recirculation through collaterals is far less likely. Canada and the Netherlands have also paused NRP for similar reasons. And so finally, we're going to talk about the erosion of public trust of organ transplantation that's recently come into national consciousness. So typically, organ donation occurs in a very precise, protocolized manner, facilitated by OPOs with oversight by several federal bodies. And this is a recent series of articles published by the New York Times by the same investigative journalist about DCD procurements, and in particular raising concerns that OPOs are aggressively pursuing DCD and pressuring families or hospitals to agree to donation. This article describes several cases that led one state's OPO to undergo a federal investigation. It was started in part due to this case. So this was a man who had an overdose with an anoxic brain injury. His family decided to withdraw life-sustaining therapies and consented to organ donation. The article doesn't explicitly talk about this, but this patient's family actually thought he was brain dead and consented to organ donation, which is obviously highly problematic. But then during the period of preparing him and identifying a recipient, he began to exhibit increasing signs of consciousness that should have prompted a reassessment of his clinical status and the decision to withdraw care. Hospital staff started getting increasingly concerned that donation was inappropriate, but allegedly the OPO pressured hospital staff to proceed. He was taken to the operating room for withdrawal of life-sustaining therapies, where he began to cry and pull his knees to his chest, and the physician refused to withdraw care. A witness from the OPO stated that if that one physician hadn't refused to withdraw care, it would have proceeded. And the man made a recovery and left the hospital, albeit with some neurological deficits. From the same state, a potentially even more disturbing case, I think, in my opinion, was described, in which another donor was undergoing DC donation, was declared dead near the limit of warm ischemic time, and underwent standoff. But after sternotomy, surgeons saw the heart was still beating and the patient was agonally breathing. And so they stopped, they closed the patient. She died 12 minutes later. The organs were not procured. It is unclear if she received any anesthetic, but it is unlikely that she did. Expert consensus was that the patient was clearly not dead after the mandated 5-minute standoff upon attempted procurement, that the OPO was pressured to declare death early due to the patient approaching the end of the viable window, right? So if true, these two stories should disturb you, right? These are gross violations of these patients' rights. These cases caused the state's OPO to be formally investigated, reprimanded, and given recommendations for reforms. And so these cases are fortunately very, very rare. However, the damage is done to public trust, right? This is a small sampling of the comment section, uniformly horrified at the contents of the story, and all express a distrust of the organ donation process. Erosion of public trust of organ donation will cause recipients needless deaths because people will not consent to either themselves or their family members to be donors because they don't want these horror stories to happen to themselves or their family, right? It's imperative that we follow protocols. We hold ourselves to the very highest ethical standards to make sure we're doing the right things by donors. Because a lot of good comes from DCD. It allows for the setting for natural death in the setting of very profound illness. It allows donors to donate their organs who would normally want to but don't meet brain death criteria. It has a huge psychological benefit for grieving families that their personal tragedy contributed to some greater good. And it saves a patient, a real patient who has end organ failure who will die without that organ, right? All of the ethical vectors point toward donation. However, it's really, really important that we behave in a protocolized manner. We don't allow the interest of organ donation to supersede the rights of donors, right? This is critically important for allowing DCD transplants to continue to occur. Okay, so in conclusion, DCD organ transplantation has unique ethical considerations, and they're justified if in alignment of the donor's wishes. Okay, family must be consented so they understand how the end-of-life process will look, and pressure to procure organs should never ever supersede the rights of donors. Okay, and these are my references. Okay, thank you so much.
Great. Thank you so much, Kristin. That was an amazing talk on ethics and NRP and DCD. We're going to go ahead and open up the Q&A session for our speakers. So please go ahead and submit your questions. And I can field those questions. And this will be via the Q&A box on your Zoom. Okay, for Dr. Trela, this is a question. It feels like the need for organs has led to contortions to create a new definition of death that distinguishes permanence from irreversibility. How is this not motivated reasoning?
How is this not motivated reasoning? I think that's a good question. I think that it's worth spending time to clarify these definitions because with DVD transplants, because brain death is a legal definition of death, we don't have to ask these questions for ourselves. But because with DCD, that the line between like permanence and irreversibility is can be blurred, right? That we use cardiac death as a proxy for brain death for irreversibility. So, I think that it begs the question of like, do we have the burden of proof to prove irreversibility before we remove organs? I don't think that's answered, right? Like, should we do something like transcranial Doppler or EEG to prove that the patients are irreversibly dead, right? And so this is a blurry line. Do we say to ourselves, is permanence good enough? Do we agree with Dr. Bernard or do we agree with Dr. Truog?
Any other comments to that question? Okay, we have another question. Are DCD donors experiencing pain during recovery after 5-minute standoff? How can this be determined?
Sorry,
so
the tree next to my house just got broken by lightning. Sorry.
Oh yeah, there's a big thunderstorm outside.
Yeah, sorry, there's a big thunderstorm outside in Chicago, and the house next to me might have just gotten struck by lightning. So sorry. So in theory that in theory that they're not experiencing pain, if we're saying that cardiac death is a proxy for brain death. But again, I think it's something that we don't truly know. I think it's highly unlikely that if the heart has not reanimated after 5 minutes, that the brain is likely unlikely to, but I think it's something that we don't truly know.
Yeah. What are the criteria for accepting a DCD heart after reperfusion? Chris, what are your criteria? You do so many of these.
Yeah. with OCS on the transplant machine, we look at how the heart looks, does the therapy performing well, and are the biochemical markers trending the right way. For NRP, we do a lot of stuff. We do echoes, we do swans occasionally. We send the images back to the accepting site, and you wean off ECMO, and you verify that that organ in vivo can support a donor. So you have a very good physiologic assessment with NRP. And I think that's one of the reasons why the outcomes may be slightly better with NRP.
And you're looking at trends and not absolute outcomes, absolute values, right? Not thresholds, but rather trend.
Correct. And
Yeah.
when I'm accepting a heart from either way, this is very different than brain dead. We get 1 million texts, videos, and lab data that continue up to the time of implant.
Yeah. And when the organ arrives, do you continue to assess any serum markers at that time, or is it more visual confirmation?
Both if they're on transmedics and OCS. Most of the NRP hearts are then back to that cold storage method, similar to brain dead donors. So that evaluation stops.
Great. The next question is, the New York Times article referenced financial motives as one of the reasons behind the cases. What are the financial considerations underlying transplants?
The
pretty
OPOs
complicated question.
They are, but the OPOs are held to standards of number of organs procured. And the organ acquisition charge is real. And there's a lot of people making money off these organs.
Yeah, it seems like there's a lot of pressure from non-providers, institutional or from the OPOs that is not related to the medical providers providing the care. Next question. In the wake of the article in the Times, what would you say to restore trust to the public? This is for anybody who wants to comment on this.
I think that's a hard question to answer, because I think once the trust is gone, it can be hard to bring back. I mean, I think we just have to make sure that we are continuing to behave in a manner, in a very protocolized manner, and always making sure that the interests of the donors are always respected.
Yeah, I really fear that this may ultimately change public policy. And those of us who participate in the use of these organs have to think of the donor and their family as much as the recipient. And if there's ever a question, we need to respectfully back away.
Next question. For anyone to contribute, if something is unknown, acts irreversibly or remnant brain function, how can something be considered ethically permissible if some level of harm may be experienced by the donor, if however brief?
Yeah, that's a tough one. I think those of us who do it believe the preponderance of the evidence is that the donor is dead and there is no pain. It's true, though, it's never been formally studied. And we have to weigh the need of our recipients, too. But if we questioned whether or not the donor was dead, we would never proceed.
And the next question is was there a strong statement from our organizations after the New York Times article And I believe there was a statement just speaking to how rare those cases are, and that the norm is it was not relayed appropriately in those articles, and so those were kind of outliers. But that was the statement suggesting that there's a bit of sensationalism associated with those articles. Does anybody else have anything to say about any other statements from organizations? All right, I think that was our last question. Thank you again to all our speakers. We're getting close to 4 o'clock, and if anybody has any other questions, you can submit them now, or we're gonna close out the webinar. All right, great. Thank you everyone for attending, and thank you so much.